Dr. Sanjay Malhotra will discuss a case on a bovine arch.
Thank you, Dr. Srinivas, for asking me to come and talk about two topics. One of them is, of course, the carotids, which you heard Dr. Khanna speaking on it, and I think there would be a bit of overlap. I was actually given to talk about a complex anatomy, including the bovine arch, and I thought I would give you a bit of introduction, what you mean by that. So, any complex coronary carotid angioplasty, we have three kinds of complexities, and one of them, of course, is the most important, and that is the arch anatomy. The second is what kind of tortuosity you see in the axis vessels, which can be the brachiocephalic trunk, which can be the common carotid, and even beyond the lesion, which is usually situated at the bifurcation. So you look at the tortuosity of the carotid vessels, and last but not the least is the complexity of the lesion, its content of the calcium, its angulation, and all these things, they lead to a problem which you can encounter while you do carotid angioplasty. So describe about arch types. It's very important that all of us who start or do carotid angioplasty, even if you're doing it as an experienced operator, you have to have an arch injection. And the recommendation is that you put this pigtail just below the brachiocephalic trunk, and you take a shot in LAO 45. And you draw a line which is at the line of this lesser curvature of the aorta, and if all the vessels they come distal to it, that means it's a type 1 arch. If the vessel, which is the proximal vessel, they start coming more and more proximal origin, the arch becomes type 2 and type 3. For example, if you see this one, if you see this one, this vessel is actually just at the level of the line which you draw from there, so you're going towards type 2, and if you go much below that, for example this vessel here, that's almost type 3. If all the vessels they come proximal to, that means if you draw a line before and this vessel is also arising from somewhere there, that becomes type 3. And the problem is that if it is type 3, it is very, very difficult to cannulate the brachiocephalic trunk coming from the groin, and that's where you may have to use an axis either from the right brachial or the right radial. But many times a type 3 arch, which is a very, very proximal origin, is a contraindication to do carotid interventions. Now, there's an important access equipment which I think all those people who do carotid angioplasty use is this catheter called the Simmons catheter or the Sims catheter, which you can go into the aorta or hook it into the left subclavian and let it come into the shape. And when you insert it, it's a straight line. So you have to pull the wire out, go into the subclavian and push it to make this shape, and then you come down into the aorta and pull it up to cannulate this vessel. And this is an important part of cannulating all the arches, which are type 2 or type 3. Then you look at the carotid tortuosity as well to be able to successfully understand how your wire will straighten all these vessels when you put them across it. And when you have a tortuosity, sometimes it would be better to come right up to that point, so at least you take away one of the curbs by using the guide catheter and then advance the wire up. This is a common anomaly which you see what is called as a bovine arch, where both the brachiocephalic trunk as well as the left carotid, they arise as a common trunk and they divide into two. For example, this is not a bad one, but this is a little worse, but then you can cannulate. And many times you can actually access this carotid, access it coming from the right radial or right brachial going this way, and also this way. But this is a very acute angle of the subclavian which you see, and it may not be very comfortable to go from here. So accessing this left carotid in this is a bit difficult. Now this is even worse. You see a lot of tortuosity. It's a bovine arch. You see a tortuosity this way, and if you have to go into this carotid, you need to use some kind of technique, some kind of special guide wires and guide catheters and some maneuvers. Many times what I use is, and I will tell you in my next case, that you actually could put in a wire into the right hand and use a blood pressure cuff to obstruct it, and that holds the wire and you can push the things up. This is very commonly done and it helps. Now, then when you go up, so for example, this kind of internal carotid, this is a internal carotid artery stenosis just before the sigmoid portion of the middle cerebral, or the internal carotid artery. It's a very tight stenosis. You have a loop there, and you have to use some kind of technique to reach there so that when you put a wire, it doesn't straighten up. So in type 2 or type 3 arch, you use sometime what you call as the front loading technique, where you can actually put a diagnostic catheter inside a guide catheter or a sheath and allow to cannulate. And you should reach to the lesion or up as far as possible without causing any kinking of the proximal vessel when you push these devices off. The most important thing is that you should not force your catheters. And if you're not able to reach, you should rethink your strategy. You may shape some wires, for example, the super stiff wire like a pigtail, put it just below the lesion and advance. And if suppose you think that it is not possible to approach, you should actually not attempt to do carotid angioplasty, because if you do that, you can actually lead into very serious complication, and the worst one is the stroke. So here's a patient which you see has got a bovine arch as well as a kind of a type 2, type 3 arch. This vessel is arising very, very close to the aortic valve, somewhere in the ascending part of the proximal part of the arch. And now if you want to do the right carotid, you need to either come from below. I don't think you can come from the left brachial, but you need to come from below and cannulate. Now you use always a Sims catheter, which is what we have used here. Now with the SIM catheter, you can actually advance a Terumo wire, let it go into the brachial, and you hold that wire, inflating a cuff. You can actually put a blood pressure cuff, inflate it to say around 130, 140 above the patient's BP. It will hold the wire, and then you can advance your catheters up. That is what I did. And now I have put an M-Pluts, which I think the cardiologists are very used to. Most of the time, cardiologists use the catheters which they are used to, for example, the right coronary, the multipurpose, the M-Pluts catheter. So it sits nicely. Now, if I had a tortuosity in my carotid here, up there, then it becomes a difficult lesion. But in this case, it is not, because it's a very straight segment. This part is straight. You can put your filter somewhere around there, and somewhere around there, it's a straight segment. But if it's a very, very tortuous angle, then your support will become worse when you come down. You may use other techniques. For example, if I go to the previous one, you can actually put one more wire or use a wider bore catheter and leave one wire inside coming from this catheter into the brachial, and that supports the pushing up of devices up. So after we have got this axis, then this is the filter. I think it's the angioguard. This is the balloon dilatation. This is the stent. Always stent from normal to normal. This is the dictum in doing carotid angioplasty. And don't be afraid about the length of the stent. It's better to use a longer stent. And then you open this one, and I think this is the final result. So what we did here, we used the M-Pluts catheter to get an axis which is almost like a type 1 arch, and my advantage was that my carotids at the top were not very tortuous. Now what you do here what you've done is that you actually have used a Terumo, use a wire and advance the catheter, which is a flexible catheter. Many times you can actually use the slip catheter to go up, and after that you put a stiffer wire and get you an axis. This is an extremely tortuous vessel, and because of the guide catheter has come right up to this point, because you can avoid this reaching at this point. So you actually negotiate up to the first bend, and then you work way up and do a final result like this, where you get a good result in that kind of a complex lesion. This is of course not my case, but it's just a show example that you can come from the left in a bovine arch, from the left brachial or left radial, and put your catheter, and of course you can angioplasty this. Now this is a very, very complex case, and where you have a sigmoid loop almost into the internal carotid artery. So what you need to do is that you need to reach up to this point at least with your guide support. And this is what you do. You have an arrow sheath, which is a sheath inside which you have used a guide catheter. You reach right up to that point, and then you actually negotiate your wire much easily. And obviously after that you can see where the guide is sitting, and then it takes the bend and the stents and whatever you do much more easily. So in conclusion, I think my time probably is up because I had about 7 minutes of time, that when you do a successful coronary angioplasty, carotid angioplasty, you have to understand a clear path of how my arch is, how my vessel anatomy or the tortuosity is, how is my lesion, and how is my distal vessel. A thought about this should be in your mind before you start a procedure. And I would recommend that people who do carotid angioplasty, they should actually not ever do an ad hoc procedure. They should think in their mind, be prepared with your strategy, and then go in, and most of the things become easy. Then if you have difficult arch, like the type 2 or type 3 or the bovine arch, you should use special catheter selection, including special wire technique, special support. Mind you, guide support is extremely important for a successful procedure and avoid complications. And your outcomes of all carotid angioplasty is dependent upon operator experience, clinical and anatomical risk factors. Thank you very much for your attention.
I think that's a good technique. What I do in cases of proximal protection, it becomes actually easier. Once you can just wire the external carotid, you just have to take your MoMA device, inflate the external carotid balloon, and then, I mean, it's very easy. Then you don't need a guiding catheter or a sheath.
So it works as a support for you. It works as a support for you.
Yeah.
Yeah.
It's a support which is built in.
So I think these are the certain things which the operators learn over a period of time, and I'm sure that you didn't know that that worked that way unless you started using MoMA device. So it is a kind of an experience which you gain over a period of time. Of course, I have not used many MoMA devices. Of course, I've used the proximal protection in the coronary, but not in the carotid bed. But I think MoMA device is a good device.
One little caution about using Amplatz catheters, just as in coronaries, most dissections with Amplatz happen when you try to disengage the catheter.
Sure.
You have to, in carotids, it's better to do it with a wire across.
Always. I mean, whenever you can put a wire inside, pull the catheter out, and then it's easy. Even in the coronary, when I'm doing a coronary intervention using an Amplatz, you can always leave the wire inside and take the catheter out.
Exactly.
It's easier.